किसी किसी केस में आती है ये।
Okay, let's start. Good morning, everyone. So basically, the topic of our today's lecture is tubulointerstitial disorders, right? So as you know, when we study the disorders of the kidney, there are basically two major types of diseases, right? Although there are some minor disorders like cystic diseases and tumors, etc. But the medical renal diseases we basically divide into two major categories. One are glomerular disorders, and the second one are tubulointerstitial disorders, right? And in order to understand glomerular diseases and how the glomerular diseases presents and tubulointerstitial disease and how the tubulointerstitial diseases presents, we need to know first the function of the glomeruli and the tubule. For example, as you all know that the function of the glomeruli is filtration. That is, this is the blood. The blood is coming to the kidney, and whatever blood is coming to the kidney, what happens that it breaks up into capillaries, which form the glomerular tuft, right? And then everything in this blood filters into the tubule, right? At the point of the glomerulus, right? And this process is called as filtration, right? And you know that in filtration, what happens that everything filters into the tubule except larger particles, that is cells and protein. And obviously, you know that the major cell type in the blood are RBCs. So except for RBCs and the protein, everything filtered into the tubule. And you know that whenever there is problem in the glomerular, that is glomerular diseases, glomerulopathies, what happens that there is problem in the filtration, right? And so what happens that because due to this problem in filtration process, the RBCs and proteins filter into the tubule, which they normally do not filter, and so the patient presents with hematuria and proteinuria, right? So similarly, what is the function of these tubules? And you all know that what happens that everything that has filtered, it goes back into the blood, right? So in the glomeruli, what is being happening is that everything in the blood is filtering into the tubules, and the reverse is happening in the tubule. That is, everything in the tubule filters back into the blood or reabsorbs back into the blood, except for harmful substances or those substances which ought to be going into the urine, right? Which need to be excreted, right? So whenever and what are these major substances? These major substances are basically water and salt, right? And one of the major function of the tubules is water and salt balance, right? So whenever there is problem in the tubules, how the patient presents? The patient presents either something like oligouria or polyuria. That is, either the tubules are not able to uh, uh, holds back the water, and so there is polyuria, or it is holding all water back into it, and so there would be oligouria. So one of these two problems can occur. And then secondly, as you know that one of the function of tubules is salt balance, right? So there is metabolic acidosis and there is hyperkalemia. So salt balance and acid-base balance. Acid-base balance would be disturbed, the salt balance would be disturbed, and the water balance would be disturbed. These are the three major functions of the tubules. So if you see the tubulointerstitial diseases, there can be two types of problems, right? One is the acute problem, and the second one is the chronic problem, right? And because there is problem in the kidney, so obviously the BUN and creatinine will rise, right? As you know that the first test you do whenever you are suspecting renal disease, you do serum creatinine or serum BUN and creatinine. And so obviously there is a problem in the kidney, so BUN creatinine will rise, right? And as I told you that there would be some problem in water balance, right? So in acute problem, if there is an acute problem in the tubules or acute problem in the interstitium, there would be oligouria or anuria, right? That is, the volume of the urine is less than 500 ml or it is less than 100 ml, right? And second thing is, in chronic problem there would be polyuria, right? So this is how you can differentiate between a acute tubulointerstitial problem versus a chronic tubulointerstitial problem. In both of these problems, there would be metabolic acidosis and hyperkalemia, because the kidney, the tubules, the function of tubules is salt balance, so there would be hyperkalemia, and the function of tubules is acid-base balance, so there would be metabolic acidosis, right? So oligouria or anuria, metabolic acidosis and hyperkalemia occurs with acute problems, and metabolic acidosis, hyperkalemia, polyuria, along with rise in DU and creatinine will occur in a chronic problem. So let's see what kind of problems can occur in the tubules or interstitial, right? There are two kind of problems that can occur. One is direct damage to the tubular epithelium, right? You know that the tubules are embedded in the interstitium. That is, the space in between the tubules or the space in between the glomeruli is called as interstitium, right? And so the problem can be in the interstitium and the problem can be in the tubule, right? And what kind of problem can occur in the tubule? The problem is damage to the tubular epithelium. And we would see that how this damage can occur, right? And this damage is always acute. So there is no chronic form of tubular injury. It is only the acute form, that is acute tubular injury, right? And it is also called as acute kidney injury, right? It is also called as acute tubular necrosis. So three terms which are used for the same disease, that is acute kidney injury, acute tubular injury, and acute tubular necrosis, right? The most commonly used term is acute tubular injury, right? But clinicians usually use the term acute tubular necrosis, right? Now, the second kind of problem that can occur in the tubulointerstitial diseases is inflammatory reactions in the interstitium, right? And these inflammatory reactions can be acute and they can be chronic, right? And obviously, histologically, how you can identify, although in tubulointerstitial diseases, histology is not mandatory for the diagnosis. All these things can be diagnosed clinically. So the biopsy is not needed, except in the transplant situations. The biopsy is not needed, right? However, if you want to see what would be in the tubulointerstitium, in the inflammatory reactions of the interstitium, there would be acute inflammatory cells along with edema in acute inflammatory conditions, and chronic inflammatory cells along with fibrosis in chronic interstitial problems. So if you go back in acute problems, right, there would be acute tubular injury and acute interstitial nephritis, right? And in chronic problems, there would be chronic interstitial nephritis, right? And I have already told you that in acute problem, there would be rise in DU and creatinine along with oligouria and urea, and then there would be metabolic acidosis and hyperkalemia. On the other hand, in chronic problems, there would be, rise in DU and creatinine, polyuria, metabolic acidosis, and hyperkalemia. Okay, so the list of the diseases which which are there in tubulointerstitial diseases are, as I told you, acute tubular injury, number one, right? And then acute interstitial nephritis and chronic interstitial nephritis, right? Then, pyelonephritis, both acute pyelonephritis and chronic pyelonephritis will also be included in this category, right? And then acute urate nephropathy, chronic urate nephropathy, and then past nephropathy, right? But the important diseases which we are going to discuss, you know, uh, today would be acute tubular injury, number one, right? Then we will discuss acute and chronic interstitial nephritis, right? Uh, Urate nephropathy is an uncommon condition, so I will just, briefly go through this urate nephropathy as well. And then pyelonephritis, basically this is infection of the kidney, right? And we have a separate lecture for acute pyelonephritis, so I will just briefly discuss chronic pyelonephritis, right? So we start with acute tubular injury, right? And basically acute tubular injury, which is also called as acute kidney injury, is the most common cause of acute renal failure, right? And what is acute renal failure? Acute renal failure is acute suppression of renal function that develops in a period of 24 hours, right? That is called as, that is if the patient develops oligouria or anuria in a period of 24 hours, then you will label that patient as acute renal failure. And one of the most common cause of acute renal failure is acute tubular injury, right? Some of the statistics that about more than 10% of patients who are admitted in the ICU develop acute renal failure, and among these 40%, more than 40 among these 10% ICU patients, more than 40% are iatrogenic. That is, they are hospital induced. And how they are hospital induced? Because you know that the drugs, many of the drugs which are given, in ICU settings are nephrotoxic, right? And when a nephrotoxic drug is given to a patient, right, it has to be, especially if the patient is old patient, the dose of the drug has to be adjusted according to the GFR, right? If that, if the dose is not adjusted, then what happens? It can cause nephrotoxicity, right? So in ICU settings, sometimes ICU staff don't care about it, right? They don't adjust the drug, especially if the patients who have a borderline renal insufficiency, the serum creatinine is slightly raised, and then if you don't adjust the dose of the drug, it will ultimately can cause acute renal failure, that is due to acute tubular injury, right? So as I told you, there are two major types of acute tubular injury. One is ischemic type and one is nephrotoxic type. Although there are some minor causes as well, but at this point, just remember that there are two major types or two major causes of acute tubular necrosis or acute tubular injury. One is ischemic type and the second one is nephrotoxic type, right? Now, I will tell you the pathogenesis of the ischemic type of acute tubular necrosis. That is, what happens that ischemia, that is hypoperfusion of the kidney, causes an endothelial dysfunction, right? That is, the ischemia, if the less blood is coming to the endothelial cells sense it, and what happens that it starts increasing the production of vasoconstrictors and it decreases the production of vasodilators. And as a result of it, what happens, there is a net vasoconstriction, right? As a result of that vasoconstriction, the GFR decreases, right? The GFR decreases, right? The second thing which the ischemia do is that ischemia cause damage to the tubular epithelial cells, right? And as a result of damage, what happens that these tubular epithelial cells die and they're shed into the lumen of the tubule, right? When they're shed into the lumen of the tubule, what happens that this is an abnormal thing in the lumen of the tubule, right? And I have already told you that whenever there is an abnormal thing in the lumen of the tubule going, what happens that the tubular epithelial cells absorb that abnormal thing and makes a mold of it, right? And that mold is called as a cast. And then that cast is shed into the lumen, right? Now these casts, obstruct the lumen of the tubules, and it decreases the flow of the urine in the tubules, flow of the fluid in the tubules, and it ultimately leads to decreased GFR, and it ultimately leads to oligonuria, right? So if we go back to this picture, so this is the, afferent arteriole. So what happens if there is ischemia, if there is less blood coming through this interlobar artery? What happens that the endothelial cells lining this glomeruli will start secreting vasoconstrictors, for example, endothelium, right? And it causes constriction of this afferent arteriole, right? So when this afferent arteriole constricts, what happens? Less blood come into the glomeruli, and so the GFR decreases. The second thing the ischemia do is that ischemia leads to damage to the cells lining the tubule, that is tubular epithelial cells, right? And so the tubular epithelial cells are shed into the lumen, right? The tubular epithelial cells will make a cast of these damaged epithelial cells, and these casts will obstruct the lumen. When the lumen is obstructed, the back pressure increases, and that back pressure leads to decreased GFR. So both of these things will lead to decreased GFR, and decreased GFR will lead to oligonuria, right? So this is the pathogenesis of acute tubular necrosis. So I repeat one more time. That is, ischemia leads to endothelial dysfunction. Endothelial dysfunction leads to increased production of vasoconstrictors, which leads to constriction of afferent arteriole, which leads to decreased GFR, right? So the ischemia causes endothelial dysfunction. Endothelial dysfunction leads to increased production of vasoconstrictors, and this leads to decreased GFR. On the other hand, ischemia causes damage to the tubular epithelial cells. The tubular epithelial cells would be damaged, they would be necrosed, and they are shed into the lumen, right? And then in the lumen, they form the cast. The cast obstruct the lumen, it causes back pressure, and ultimately this leads to decreased GFR, and ultimately it leads to oligonuria, right? In nephrotoxic type of acute tubular necrosis or acute tubular injury, the same thing occurs. That is, nephrotoxin also leads to endothelial dysfunction, and as a result, there is increased constriction of vasoconstrictors. On the other hand, the nephrotoxic drugs also causes direct damage to the tubular epithelial cells, and as a result of that, there will be necrosis of tubular epithelial cells, and the tubular epithelial cells are shed into the lumen and they form the cast, right? So I hope you understand the mechanisms, and generally this damage to the tubular epithelial cells occur in the proximal tubular epithelial cells and the epithelial cells of the ascending loop of area. Now the nephrotoxic type, I told you what is the mechanism. Now what are the major drugs, and what are the clinical scenarios in which that occurs? The major drug is, one of the drugs is aminoglycosides, for example, gentamicin, and you know that they are given IV, and they are given to cover gram-negative drugs, gram-negative organisms, and gram-negative organisms, are one of the major, organisms which cause hospital-acquired infections, right? So patients who are admitted in ICUs, they need an antibiotic coverage, and to cover the gram-negative organisms, aminoglycosides are given. And aminoglycosides are nephrotoxic drugs, right? So whenever an ICU patient aminoglycoside is given, it has to be adjusted according to the body weight of the patient, according to the serum creatinine, right? And so the dose has to be adjusted. And if there is borderline renal failure, the dose has to be decreased, right? And if the dose is not decreased, then it can cause nephrotoxic type of acute tubular necrosis. The second common types of drugs are radio contrast agents, right? And you know, the radio contrast agents, they are given when a patient needs a contrast CT scan. For example, if the patient is admitted for a bowel injury, right? That is a bowel perforation or gallbladder perforation, etc. And you need, you know, a patient is admitted in the ICU setting and or in the ward setting, and you know, you need a CT scan with contrast. CT scan of the abdomen with contrast, right? And these contrast drugs are nephrotoxic, right? And you know that whenever this contrast is needed, the radiology people always ask for the fresh serum creatinine. Why they ask for fresh serum creatinine? Because you know they know that they are nephrotoxic drugs, and if the patient's serum creatinine is raised, then the dose has to be adjusted, right? So heavy metals, but these heavy metals are rarely used. So the two major drugs which can cause nephrotoxic type of ATN are number one, aminoglycosides, and number two, radio contrast agents, right? Okay. So as I told you that biopsy or pathology is not needed, but if you do it, like what you are going to see in the early stages of acute tubular necrosis or acute tubular injury, you can see that there is these the epithelial cells which are lining the tubules. These are the tubules, right? This is one tubule, this is another tubule, this is another tubule, right? And these are the tubular epithelial cells. And you can see that they are damaged. And how you can identify they are damaged? That is, you can see that the border becomes very fluffy, right? And irregular, right? And the cell cytoplasm is more eosinophilic, and there is degenerated appearance of these tubular epithelial cells. They become enlarged, and their cytoplasm is more eosinophilic, and you know the border is more fluffy and irregular, right? So this is, you can see this is early tubular injury. In the later stages, the tubular epithelial cells die, and you can see they form the cast in the lumen, and you can see this is the cast. This is all dead tubular epithelial cells which are forming the cast in the tubular lumen of the tubular epithelial cell. This is the healthy tubule, and you can see this is the tubule, and these are the tubular epithelial cell lining. And these are the damaged tubules with all the epithelial cells dying, and they are shed into the lumen, and they're forming the cast, right? This is a tubular epithelial cell which shows early signs of damage. There is a fluffy border and more eosinophilic cytoplasm, right? Okay. Now, as I told you that the biopsy is not needed mostly, and so how you can identify clinically? Clinically, as I told you, oliguria along with rise in BUN creatinine. That is the patient, the typical setting would be an ischemic type of acute tubular necrosis. Ischemia can be, for example, the patient has a heart failure and the heart is not pumping blood, and so there is less blood coming to the kidney, right? So a patient with myocardial infarction or heart failure is admitted in the ICU, right? And suddenly the BUN and patient develops oliguria. That is, you are a doctor who are appointed in the ICU, and you notice that the the urine output is decreased, and the urine output is decreased less than 400 ml, right? And so you order a BUN creatinine, and the BUN creatinine is raised, right? So you identify that this is the acute renal failure. The next step you are going to do is that you are also identify that in the labs there would be decrease in bicarbonate, so there is metabolic acidosis, and there is rise in the potassium, so there would be hyperkalemia. The next test we will do is urine analysis, and in the urine analysis, if you find tubular cast, this is pathognomonic of acute tubular injury. This is diagnostic of acute tubular injury, right? So I have given you the typical scenario, right? Because you need to identify clinically this condition. So the typical scenario, as I told you, a patient admitted in the ICU setting, right? And for example, the patient is admitted after severe diarrhea, right? Or severe vomiting, right? So you know that severe diarrhea and vomiting is one of the cause of hypovolemia, right? Or hypovolemic shock, right? And you know, you are the concerned doctor, right? And you identify that the urine output is decreased. The urine output is decreased, and so you will order serum BUN creatinine. The BUN creatinine are high. There is rise in the potassium ions. There is decrease in the bicarbonate ions in the labs, and you order urine analysis and their tubular cast. So this is ischemic type of acute tubular necrosis, right? Another scenario can be a patient who had a road traffic accident, right? And the road traffic accident, the patient has lost a large amount of blood, right? And so you are a doctor who are appointed in the emergency room. So you receive that patient and you obviously you pass the IV line, you pass the catheter, and you are doing an input output charting, and you identify that there is less urine output and the BUN creatinine are high. So this is again a scenario where there is acute renal failure, right? And so in other labs you identify there is hyperkalemia, there is metabolic acidosis, and so you order urine analysis and there would be tubular cast. So this is again a scenario of acute tubular necrosis ischemic type, right? So I hope all of these examples made very clear to you the ischemic type of acute tubular necrosis. In the nephrotoxic type, the typical scenario would be a patient admitted in the ICU for some infection, for example, lung infection. And for that lung infection, you are giving a combination of antibiotics, and that combination includes aminoglycosides, that is gentamicin, right? And so what happens after that? There would be rise in the BUN creatinine, there would be decrease in the urine output, there would be metabolic acidosis, there would be hyperkalemia, and on urine analysis there would be tubular cast. Another scenario would be a patient who is admitted and who has some bowel injury or bladder injury or gallbladder injury, and you need an CT scan with contrast. So after that, the patient develops oliguria, that is decrease in the urine output, right, less than 400 ml. And what happens that you order a BUN creatinine, the BUN creatinine is high, so you identify this is the acute renal failure. On urine analysis, if you find tubular cast, this is nephrotoxic type of acute tubular injury secondary to radio contrast agents, right? Pathogenesis, I already told you that the ischemia causes damage to the tubular, ischemia causes endothelial dysfunction and damage to the tubular epithelial cell. Endothelial dysfunction leads to increased production of vasoconstrictors, it leads to constriction of afferent arteriole, and it leads to decreased GFR. Damage to tubular epithelial cell leads to necrosis of tubular epithelial cells. There would be cast in the tubular epithelial cells which will obstruct the tubular lumen and cause decreased GFR, right? So this is all about acute tubular injury. The next is tubulointerstitial nephritis. And as I told you, tubulointerstitial nephritis can be of acute and of chronic category, right? So acute is called as acute interstitial nephritis. It is also called as acute drug-induced tubulointerstitial nephritis. And the chronic is called as chronic interstitial nephritis or analgesic nephropathy. So let's see first, acute interstitial nephritis. So acute interstitial nephritis is also called as acute drug-induced interstitial nephritis. And the common drugs which do this are number one, penicillin. And you know that penicillins are common drugs which are given for skin infections, for throat infections, for upper respiratory tract infections, right? Sulfonamides, and you know that sulfonamides are given for urinary tract infections. And NSAID. And NSAID, you know that it is anti-inflammatory drugs. They are given for pain and for to reduce inflammation, etc. So these three classes of drugs can lead to acute drug-induced interstitial nephritis or just acute interstitial nephritis. Now, what is the pathogenesis? The pathogenesis is type 1 hypersensitivity reaction. That is, these drugs, they are not proteins, they act as haptens. That is, they bind to some portion of the tubular epithelial cell, some protein of tubular epithelial cells, and then they become immunogenic. And that leads to a type 1 hypersensitivity response, that is an IgE mediated hypersensitivity response. So Ig, it leads to recruitment of eosinophils and mast cells, right? Eosinophils basically, and it leads to damage to the interstitium, right? The clinical scenario is very, very, characteristic, and there is a classical triad of fever, oliguria, and rash, right? So the patient presents with fever, oliguria, and body rash, and along with that, the patient will also complain of decrease in the urine output, right? That is oliguria. That is, so the classic triad of fever, oliguria, and rash, and you will do a blood CT, and you will do obviously whenever there is oliguria, you are going to do BUN creatinine. So BUN creatinine would be high, so you will identify this as an acute renal failure, and on TBC you will find more eosinophils, that is eosinophilia, right? And you will do a urine analysis, and on urine analysis you will find eosinophil urea, right? So fever, oliguria, rash, rise in BUN creatinine along with eosinophilia and eosinophil urea is very characteristic of acute drug-induced interstitial nephritis. And the treatment is very simple, that is just withdrawal of the drug will lead to withdrawal of the symptoms. Again, the biopsy is not needed, but if you do a biopsy, you will see a lot of inflammatory cells along with edema in the interstitium, right? You can see these are the tubules. This is another tubule, and in between the tubules, this is interstitium. It looks very busy, and why it looks busy? There are a lot of inflammatory cells, and these cells with eosinophilic granules are basically eosinophils. So a lot of eosinophil-rich interstitial infiltrate, right? So this is acute interstitial nephritis. So acute interstitial nephritis, the patient presents with fever, rash, along with decreased urine output, right? You will do CBC in BUN creatinine. BUN creatinine would be high, so there would be, this is acute renal failure. On CBC, there would be more eosinophils, right? You will do urine analysis, and you will find eosinophils in the urine as well. So this is characteristic, this is diagnostic of acute interstitial nephritis or acute drug-induced interstitial nephritis. Pathogenesis is that sulfonamides, penicillins do this, right? Sulfonamides, penicillins, and NSAIDs. And the pathogenesis is that these drugs act as haptens. So they bind to some protein of tubular epithelial cells, and it elicits a type 1 hypersensitivity response, that is an IgE mediated hypersensitivity response, right? And so it causes inflammation in the interstitium and edema in the interstitium, which is eosinophil rich, right? The second category, that is the chronic category of interstitial nephritis, is chronic interstitial nephritis, which is called as analgesic nephropathy. And the name is telling you analgesic nephropathy, and analgesics are pain drugs. So these are the patients with chronic pains, that is, for example, osteoarthritis, for example, rheumatoid arthritis, for example, back pain, disc prolapse. So all these patients with chronic pain diseases, chronic pain disorders, right, or patients with migraine, so any chronic pain disease, they need combination of analgesics. And typical combination is acetaminophen and aspirin. So this typical combination of acetaminophen and aspirin, it causes analgesic nephropathy, right? And they do analgesic nephropathy. They do damage by by altering the production of prostaglandin, and it ultimately leads to decreased GFR, but slowly over a period of time, right? And so the typical scenario would be a patient will come to the clinic, not the emergency department, come to the clinic, and the patient will say that they have, more, they are producing more urine, that is polyuria. And the patient will also tell you that, he or she has a chronic pain disease for which they are taking aminoglycosides, they are taking acetaminophen or aspirin, right? And you will do labs and you will find out that there is metabolic acidosis, there is hyperkalemia, and there is rise in biliary creatinine. So you will come to know that this is chronic renal failure, not acute renal failure, this is chronic renal failure, right? And so this is again a classical clinical scenario of analgesic nephropathy. There are various complications of analgesic nephropathy, but one of the complications which I want to tell you is renal papillary necrosis, right? And what happens in renal papillary necrosis is that the tips of the renal papillae, they are shed, they die and they are shed into the urine. So typically the patient presents with passage of tissue fragments in the urine along with fever, right? And along with they are unable to hold their urine, that is they would be urinary incontinent, right? The typical clinical scenario, the patient comes to the emergency department. Now this is an acute condition, this is not a chronic condition. The patient comes to the emergency department and the patient complains that there is oliguria, that there is a passage of tissue fragments in the urine, there is fever, and there is urinary incontinence, right? That is, the patient is no longer able to hold the urine. So this typical clinical scenario is of renal papillary necrosis. It can occur after obstructive neuropathy. Obstructive neuropathy, it can occur after diabetes, but the typical clinical scenario is after analgesic nephropathy, right? So you in the exam you need to differentiate between a clinical scenario of analgesic nephropathy, which would be a chronic condition, and a typical clinical scenario of renal papillary necrosis, which is an acute condition, which is one of the complications of analgesic nephropathy, right? Urate nephropathy can be acute urate nephropathy and chronic urate nephropathy, right? And as I told you, you can already identify a clinical scenario. The clinical scenario of acute condition is oliguria, hyperkalemia, and metabolic acidosis, along with rise in biliary creatinine. And in chronic conditions, there would be polyuria, right? And there would be hyperkalemia, and there would be metabolic acidosis. Now, how you will identify that this acute renal failure is due to a urate nephropathy? The typical clinical scenario is, as you know, that the uric acid, from where the uric acid comes from DNA and RNA, right? And the patients who are undergoing chemotherapy, the chemotherapy are damaging the tumor cells. They are killing the tumor cells, right? And tumor cells have a lot of DNA and RNA, right? They have a large nucleus, right? So when these tumor cells are dying, they are producing that DNA and RNA are damaging, dying in a high amounts. So there is a lot of production of uric acid acutely, and the patient, the kidney is not able to excrete that uric acid in time, and so what happens? The uric acid builds up in the bloodstream, and they go into the interstitium, and they cause it interstitial nephritis, which is called as acute urate nephropathy. Chronic urate nephropathy, the typical clinical scenario is of patients with gout. And that in gout there is hyperuricemia, but this is a chronic condition, right? And so these patients have a chronic hyperuricemia. So chronically, this uric acid would go and damage the interstitium, and it leads to chronic urate nephropathy, right? So this is acute urate nephropathy and chronic urate nephropathy. So acute urate nephropathy, typical clinical scenario, a patient who is undergoing radiation or chemotherapy for some cancer, for lymphoma, after which the patient suddenly develops oliguria, and you do a urine, you do BUN creatinine, and there is rise in BUN creatinine. Further labs show hyperkalemia and metabolic acidosis. So this is acute urate nephropathy. Chronic urate nephropathy, if in the clinical scenario the scenario is telling you the patient is of gout. Now, that patient is of gout, and that patient develops polyuria over a period of time. You do labs, they rise in BUN creatinine, so this is chronic urate nephropathy. So everything is similar, except the scenario, the acute and chronic interstitial nephritis. The difference is that in acute urate nephropathy, there would be a tip-off of chemotherapy or radiation therapy for cancer. In chronic urate nephropathy, there would be a tip-off of a patient who has a known case of gout. So here you can see this is urate nephropathy. These are uric acid yellowish crystals which are deposited in the urine. Again, you can see this is the uric acid crystal which is deposited in the interstitium. One last thing is cast nephropathy. And this cast nephropathy occurs in patients with multiple myeloma. In multiple myeloma, the patient is excreting benzones proteins in the urine. So this protein, deposits in the interstitium. It forms cast, which is called as cast nephropathy, right? There is no need to go into the detail of cast nephropathy. This is the cast which is typically formed in the cast nephropathy of multiple myeloma. Just remember that cast nephropathy occurs in multiple myeloma. In multiple myeloma, there are other problems in the kidney like light chain deposition disease, amyloidosis, and dense zone proteinuria. One last thing I just want to point it out, because this would be covered, in when you will do pyelonephritis. There is an acute pyelonephritis and there is a chronic pyelonephritis. And there are two types of chronic pyelonephritis. One is called as reflux nephropathy, and one is obstructive type of pyelonephritis. The reflux nephropathy is whenever there is a problem in the ureter, which is in the wall of the urinary bladder, that is intravesical part of the ureter. Typically, it is obliquely placed in the wall, in the muscle of the urinary bladder. But in some patients, it is straight. And so, what happens that during urination, during micturition, when the bladder wall constricts, this intravesical part of the ureter do not constrict, and there is reflux of the urine into the kidney. So this is called as reflux nephropathy. The urine goes back during urination into the kidney, and they cause pressure atrophy of the renal parenchyma, which is called as the reflux nephropathy. And the second condition is that if there is obstruction of the urinary pathway, then it causes obstructive type of uropathy. So these reflux nephropathy and obstructive uropathy, they also cause chronic inflammation and damage to the tubules, which is called as chronic pyelonephritis. I just touch this topic because it would be included when you will do obstructive uropathy and chronic pyelonephritis, which would be covered in separate lectures. So this ends our lecture. So today we have basically discussed tubulointerstitial diseases, and the categories which we have discussed are: number one, acute tubular injury, right, which can be ischemic or nephrotoxic type, and we have discussed acute interstitial nephritis, which is caused by drugs, and there is a chronic interstitial nephritis, which is also called as analgesic nephropathy. It is also called as analgesic nephropathy, and one of the complication of it is acute papillary necrosis. And then we discussed urate nephropathy, right? Acute urate nephropathy and chronic urate nephropathy, right? So if there is any question, then you can ask at this point. Any question from the participants?